Good afternoon. Welcome to a webinar to deepen our understanding of COVID-19 in Virginia. Our question today is about COVID-19 statistics, what the numbers can and cannot tell us about what is happening in our communities. I'm David Poole. I'm the Executive Director of the Virginia Public Access Project. VPAP is a nonprofit, nonpartisan group dedicated to enhancing public understanding of Virginia government and politics. The pandemic has been with us 5 months now. Virginia has nearly 64,000 confirmed cases and more than 1,800 deaths. We've seen a lull recently and we're grateful for that. But without a vaccine, it appears we will be living with the coronavirus for many months ahead. In my lifetime, I've never seen a news story that places a bigger emphasis on numbers, the data. The Virginia Department of Health website, which began as a bare bones list of numbers of deaths and cases, now has an array of measures that's available to everyone. In this era of big data, there is an expectation that all we need is the right algorithm and a few charts to explain everything. But it's just not that easy. And today, that's what we're going to explore. Our panelists look at the data from 4 different vantage points. M. Stevens is the Respiratory Disease Coordinator for the Virginia Department of Health. Luanne Rife is the Health Reporter for the Roanoke Times. Dr. Michelle LaRue is the Senior Manager for Health and Social Services at CASA, which assists and advocates for immigrants and Latinos. Bob Holsworth is a longtime observer of Virginia politics, who has spent the last several months producing a running analysis of COVID data trends in Virginia.
As you've mentioned, we're providing a number of different statistics, so case counts, death counts, but things as well like testing and demographics. So there's a lot more information available there. And then I think it's just important to mention that there are a couple of the reasons for visiting the weather report and for visiting the COVID data are a little bit different. So you may visit the weather report for information that's immediately actionable. Should I bring an umbrella today? Do I need a heavier coat? With COVID, the daily data are more useful for situational awareness, and we should be making our behavioral changes based more on trends over time rather than on the immediate case count. So looking at it on a daily basis is really more for the situational awareness than that kind of actionable measure that you take when you're looking at the weather report.
Because the numbers that are released today are telling you what was happening a week, 2 weeks, maybe even 3 weeks ago. Is that correct?
That's correct. I mean, looking at the data, it seems that there's about a week between when somebody is exposed and when they start to develop symptoms, and then maybe another week between when they develop symptoms and when they seek care, a little less than a week but for them to get the testing results back, and then about a day for the lab to send the test results to VDH and a day for VDH to report them publicly. So all told, it's about 2 weeks from when the person first became sick and about 3 weeks from, and this is like a median timeline, and about 3 weeks from when that exposure actually happened. So what we're looking at today is really what happened several weeks ago.
Okay, and we've talked in past conversations, Em, and you've explained to me that to epidemiologists, the epi curve is the most useful way to look at the data when there's much more data is finalized, like at the end of the flu season. But what does it mean with the public trying to look at this data daily or weekly? Is that really what it was built for?
So the epi curve, you're correct. It really isn't meant for real-time viewing or decision making. So we're presenting the data by day in 2 different manners. We're presenting the epi curve, which is by onset date or the date of hospitalization or the date of death. That's really about when the event occurred. And you mentioned that's the more helpful information once we have the data finalized. We're also presenting data by the report date. So when VDH is publicly reporting it for the first time, and that's so that we know that the public is trying to download our information on a daily basis and make the comparisons themselves to look at what those trends look like. What we're reporting today, how does that differ from what we reported yesterday? So trends in reporting versus trends in illness onset, and taking them together or interpreting them together really is the best way to try and understand what the actual pandemic curve looks like in Virginia.
Well, I mentioned earlier that, I think we're all looking for certainty. We're looking for certainty of what risks are tolerable for us to take. We're looking for certainty of, what is the future, what's the trends look like. But so we want certainty, but epidemiologists, you're trained to embrace uncertainty, right? There's all sorts of factors that are moving at once. So how can you talk about that a little bit? The embracing uncertainty. Is that something the public is going to have to learn to get comfortable with? It
really is. So there are several methods that we introduce uncertainty into our data and what we're reporting publicly. We've already mentioned the lag between when a case first starts or when a person first gets sick and when that case is reported publicly. There's also uncertainty in the science itself. We still don't really have a good idea of how many cases are asymptomatic, how many infections are around that aren't going to end up in our surveillance data because they'll never seek care. We are waiting for good science on that, so that's another method of introducing uncertainty. And then just the truth of surveillance data in what it means introduces uncertainty as well. In a normal flu season, flu is what I'm used to talking about. So in a normal flu season, we say that a little less than half of people who have an infection are ever actually going to seek care. So the majority of people who get the flu are never going to end up in a database because they're never going to meet that point to get into our surveillance systems. So the introduction of that bias and that uncertainty as well does play another factor in what we can report and how people can interpret the data. So as EPIs, we're used to kind of dealing with the fact that we know there's underreporting, we know there's a reporting lag. Most of the time we have a little bit better of a base in the scientific literature because most of these viruses and bacteria have existed for years, not just for a few months in humans. But we are used to dealing with that uncertainty. We typically use what we call a hindcast or a nowcast, which in forecasting behavior is what we're trying to say. We're predicting what's happening now, we're predicting what just happened because the data aren't really available yet. And so we're used to kind of trying to interpolate that hindcast and nowcast and act on those information.
Okay. So there have been times where the VDH has had to revise or restate its data. I think the thing that people remember the most is when it was learned that the viral test and the antibody test had been commingled, those numbers. Were you surprised by the reaction of the media and the public to that restatement?
I was surprised. I think it's worth noting that we're used to, as mentioned, we're used to our data being preliminary and there being some uncertainty in it. And then the reaction where people expect us to have a specified method already established is definitely something that is taking a little bit of getting used to. And replying to things on a daily basis, publishing data on a daily basis is very new to us. And then in general, because we are getting requests from so many different angles and we're changing our methods based on what new science there is available, as well as what the question being asked is. It is interesting when the question changes, and so we change our methods and then the public only sees the method changes. It's definitely an interesting interaction between public health and the public. So for the antibody test, we thought we were trying to answer the question, how many people are getting tested, when in fact people wanted to find out how many people are getting tested that could become a confirmed case. So changed our methods based on the change in the question being asked.
Okay. And we're going to hear from Dr. LaRue in a few minutes, but COVID has disproportionately impacted Black and Latino communities. Can you talk about the reasons why many of the positive tests, particularly early on, were not tagged with the patient's race or ethnicity?
Yeah, so most of the testing data that we receive comes in to our system electronically. The labs that are sending it in have a list of variables and fields that they're required to send. This is all based on some standardization that's happened over the past couple of decades. But the race and ethnicity information is required to be sent in that electronic lab report if it's available at the lab. Public health and healthcare treat patient health information. We want to make sure it's protected as much as possible. So the question about whether that makes people feel safe if they're not in what has been identified as a high-risk setting, I hope that people don't make that interpretation. In general, when dealing with something that's so unknown, err on the side of caution, err on the side of it's in your community, take all of the precautions that you can. But then there's also just the point to be made that it's getting introduced into poultry plants and long-term care facilities through contact with the community. So it doesn't pop up out of nowhere in those communities. It is introduced from spread that's happening in your general neighborhood.
Okay, and finally, can you tell us, are there any plans for widespread antibody testing to determine the prevalence of this disease?
Sure. So we're actually pursuing a seroprevalence study at this point. We are going to be testing, the goal is to test 1,000 individuals in each of the 5 health regions in Virginia to try and make it geographically representative so that we can say that we think in this part of the state, this number of people have been infected at this point. So that testing is actually currently occurring, and we're gathering the data for that. The goal is to be able to release the preliminary data in the next month or two, so that we can try and say, this is the proportion of the population that we think has actually been infected. Ideally, by that time, we have some more science on whether previous infection provides protection to future infection, but hopefully we have that science when we have those data.
Okay, great. Well, thank you so much, Em. And now we'll turn to our second panelist out in Roanoke, Luanne Rife, who covers health for the newspaper there. And I guess pretty much for the last few months, not just health, but specifically COVID-19. Luanne, welcome.
Thank you. Thanks for having me. Yeah, the other day I looked and I saw that I've written probably about 100 stories so far on COVID. So
wow.
It's been quite a ride.
So you describe yourself as not really a data person, and the Roanoke Times doesn't have an analytics staff or a data visualization staff. So how do you make sense of all these numbers that tumble out of the VDH site each day?
Yeah, so it's true. I'm not a data person, and I can get myself tangled up in Excel pretty quickly. But I've always been intrigued by math word problems and by trend lines, especially as they apply to public health. But usually, as Em explained, you're looking at it long term. You're looking at data that comes in, and you can take a good deep dive and look back. With this, there's just so much data coming in, and VDH has taken a lot of criticism, I think, by, why aren't you showing this? Why aren't you showing recovered cases? Why are you putting up this way? And so on and so forth. But if you poke around and look at some of the other states, Virginia is really doing its best to push as much out there. And I think Em also, hit on that people want actual definite, this is exactly how things look today and this is what will look like tomorrow, but you can't get that. I mean, you just have to sort of look at the trend lines. So I think, I look at it as looking at the numbers and trying to put them into some context that would help readers understand what this does mean to them. To say there's 500 new cases today really doesn't mean anything without knowing the context of how the disease has progressed in not just statewide, but in particular regions.
I'm sorry, let me just jump in and ask you, do you think in some ways not being a real data head has helped you kind of tell the narrative better? I know recently you had a couple of stories that stand out to me about a handful of restaurants, or maybe 3 restaurants in Roanoke, and then the Myrtle Beach spring or beach trip people coming back. So talk, has that helped you, I guess, perhaps, or to focus more on the narrative?
Well, so, I think that I've looked at the data as people. So, you know, each case, each death, each hospitalization to me means a person. And with each person comes a story. And, you know, you start hearing trends of things that are happening in your community, you know, whether there be an outbreak or, you know, people have heard, oh, this has happened in this place. And so the data have been very helpful in being able to look at and help tell that story, to help tell the people's, you know, stories. But, you know, I think that, you know, sometimes this has been a really data-driven story. I mean, the governor has made clear that he was going to use science and the data to make decisions, to make policy decisions. And so I think in order to understand what he's doing from a policy perspective, you have to understand what the data are telling him and what is it telling you in your community, because he is making statewide decisions, but what something looks like in Richmond is totally different than what it looks like here. And so, you know, and for example, I get reports from different health districts, and a couple of weeks ago, Mount Rogers, their numbers looked really high and they had deaths, and they have had no cases. And so if you look at the data, then you find out, oh, why is this happening? And you start asking questions from it, and you find out, oh, there's an outbreak in a nursing home that is killing people. That's a story.
Okay. Let's talk about nursing homes and privacy, or privacy in general. You know, there's this balance between you want you know, protect a patient's privacy, but you also have the expectation that the public has the right to know what is going on in their community. What's the threat level in their community? Has that how has that affected your ability to tell the story?
So that's been one of the most frustrating things, I think, for reporters and for the public to understand. You know, when the outbreaks first started in long-term care, families who have had hardly any contact with their family members, especially those that, you know, can't communicate very well, you know, they're relying on whether or not they're going to get reports from the assisted living or nursing home, and they don't really know, and they hear things in the community, and public health can't tell you unless the facility tells you. You know, this, and then there was the sense of, you know, we have CNAs who work in several facilities, and the facilities couldn't know one between the other because of this privacy. And so there was a carve out for that. So, you know, even to this day, even though VDH is now putting skilled nursing and assisted living outbreaks on a separate part of their website, if you go to, you can't see where any of these outbreaks are occurring by locality. It's only by the 35 health districts. So if we have 8 outbreaks in Roanoke and Allegheny County health districts, that could be, you know, over this huge geographic area. And so I've been writing a lot about the long-term care, but it wasn't until I wrote a story about there's an outbreak at a church, so my phone was ringing off the hook. Is it my church? You know, I don't know. I wrote about restaurants. And I think we had 5 going on at 5 outbreaks at the same time. Well, I knew what 3 of those restaurants were because they had let people know, but I didn't have time to contact each of them, and I didn't know the other 2. And so I thought the story was, there are these outbreaks going on in these restaurants, and it really didn't matter which ones they were, but this is how the disease is spreading. And again, my phone's ringing off the hook. Which restaurants are these? We go out to eat. And I said, you know, why is this? Why are they keeping this information from us? And they said, it's the same part of code that doesn't allow you to know if, you know, the nursing homes. And, you know, and people are like, well, we don't go to nursing homes. You know, we go out to dinner. But, so there's a failure to see all of the connections, I think. Yeah, it's
Okay.
difficult.
Thank you. And one more question. You know, if the polls have shown that conservatives and liberals look at this pandemic through very different political lenses. And as we've moved into the 5th month, have you seen this tendency become more pronounced out among your readership?
I wouldn't say I would say that it's more pronounced, and I sort of try and stay away from the politics of it all and this silliness about whether you wear a mask, whether you support the president or not by not wearing a mask. It seems silly to me. What I've seen is a shift in the way people view the threat of the disease. Like when it first started, and there was so much that was unknown, there was this fear that it was lurking everywhere. And so, you know, you still have people on one side who think that it was all a hoax or is, and people who are just still turtles and are afraid to go in their own backyard. And I don't think anything I can write is going to sway or educate people that are entrenched in their beliefs. So, but I do believe that just about everybody else is just hungry for good information to know what's going on in their community, and I've seen that throughout.
Okay, great. All right, Luanne, thank you so much.
Thank you.
And now we'll turn to our third panelist, Michelle LaRue. She's a senior manager for health and social services at CASA. Welcome, Dr. LaRue.
Thank you.
All right. Your group is an advocate for immigrant and Latino communities. And as you look at the various data dashboards, do you see a reflection of what's happening in your community?
I do. I think that, you know, our communities weren't able to stay at home as much as other sectors. Many work in construction and other industries that stayed open even through those initial stay-at-home order phases. And so I think that increased our risk of exposure and then getting the virus. And then, you know, many of our community members live in very congested living situations, many times having to have multiple families living to one unit, which just increases the risk of then spreading it to others. But also there's factors even with, I think that the testing itself. I think I agree with some earlier statements that under-testing or under-reporting is probably going on. And with our community specifically, I went to get tested once already, and they didn't mark me down as Latina. On the form, thankfully, you know, I am very proud Latina, and I noticed and I corrected the form. But I wonder how often even things like that are happening. But our community also has barriers to getting testing, especially early on. Before widespread testing, many relied on private urgent care centers or private providers. And our communities have really high levels of uninsured. And there's also, you know, fears of going to the hospital, whether it's fear of immigration or fear of how much it's going to cost, that I think drove down the numbers for us, especially in the early phases. Transportation is another barrier that many of our community members face, especially as we get further and further away from metropolitan areas. There's less public transportation. We really don't want people who may have the infection also taking public transportation. So as more testing sites go up, I think we need to really look at this data sets and see what are the hotspots, what are the areas most affected, to make sure that we're bringing testing to those areas, knowing that transportation is such a barrier, especially for certain sectors. And even if you have a car, if you're gravely ill, it may not be safe to get behind the wheel. So these are all things that we've seen mostly in the initial phases, but I think some of these are still a factor even today.
Okay. And are there any numbers on the percentage of Latino workers who have the option to distance work? I know, those of us in the information technology world, well, it's just you quickly work remotely, and not much has changed. But so, are there any statistics about distance work in Virginia?
Specific statistics I'm not aware of. I know traditionally, like at CASA, we also had very seamless switch to virtual work. We never closed down. We were able to transition, especially in my department, to help people enroll in public benefits and connect them to health services pretty seamlessly, telephonically or virtually. But many of our community members do not have that option. And we've been working with individual employers, labor unions, and our community at large in trying to make sure that the right strategies are put in place, or that they know, what their rights are to when they do report to the workplace. We've seen traditionally, I think, this pandemic has really brought to the surface issues that we've been fighting against for many, many years. Language access is a big one right now, and as well as some labor issues and labor safety issues. So making sure that both employees know their rights, and the employers are truly being supportive for their community, for their employees. Making sure that people have PPE, that they supply it if they don't have a way of getting it themselves, and that social distancing is observed in the workplace. And so we've seen some hits and some misses on that as well.
So speaking of language barriers, the state officials have really talked a lot about the details of its contact tracing program, which is just getting ramped up. From what you've seen, how is this working in your community?
I think language access is a big part with contact tracing. I think we need to do a really good job of really being able to have good quality conversations with community members, and making sure that we have bilingual contact tracers to be able to make those calls and have those conversations is going to be critical. Otherwise, we're going to fall short, and we're all interconnected. I know we're talking about specific sectors, but when it comes to a pandemic or infectious diseases in general, we are all very interconnected. And so I think for the health of the state and the health of the nation, we need to make sure that we are making sure to have those language capacities to be able to serve everyone and make all of these calls. And so we're working really hard to drive people to apply as well, and making sure that we also are working with the community that they answer the call. I know that there's been some scams and some fears, some robocalls, and people don't tend to answer calls that are not within your contact list already on your phone. And so making sure to also share the messaging that to answer the contact tracing calls when you get them.
Okay, great. I saw a quote in the Fredericksburg paper that someone had posted on Facebook saying what COVID and racism have in common is that people don't believe that it exists until it happens to them. Does that ring true to you?
Oh, very much so. The language access piece, just as one example, we've been sounding the alarm of the importance of having language access, especially in the healthcare system, in communications to, there was a little bit of lag, there was a lot of lag, I think, in making sure that the information was getting out to all different sectors, whether you're young versus old, Spanish speaking versus English speaking. And we really need to make sure that the information is getting out to everyone in a timely manner, or we're going to have lags or difficulties in getting beyond this pandemic. And there's been a lot of other, I can give a lot of other examples. I think the fact that our community is so suffering so much and having the highest rates across the state, I'm worrisome that this will create more racism against the Latino communities, and people are going to, treat our community members differently, thinking, all of you guys are infected, and how that might play out throughout this pandemic and even potentially beyond.
Right. Dr. LaRue, I should have probably started with this. I know I've seen statistics on certain regions of, the disproportionality of the number of Latinos represent a certain percentage of the population, but twice that of the cases. Do you have some statewide numbers or regional numbers that would help people understand the disproportionality for your community?
Yes, I mean, just looking here at the state website, you know, just an infection rate, it's nearly 10,000 more than the next demographic after us. We're clearly, I mean, just eyeballing it, I mean, it's close to more than all the rest combined. It may be just about 50-50. So our community is very much disproportionately getting hit extremely hard in infection rates right now.
Right, okay. Well, thank you so much. And we'll circle back with some questions toward the end. And now we'll bring in our final panelist, Bob Holsworth, a political commentator and a consultant with Decide Smart. And I should in full disclosure, tell you that VPAP, when we got started in the mid 90s, we partnered with Bob at VCU Center for Politics. So welcome, Bob.
Good to see you, David. Good to see everyone.
So how did a mild-mannered political commentator get into the COVID-19 data business?
You know, David, I think what happened was that when it hit, I think it just became pretty evident that this was certainly a once-in-a-generation and maybe once-in-a-lifetime situation. And I wanted to trace how it looked in Virginia. And then beyond that, I'm a little bit obsessive-compulsive, not quite like you, but still have that in me. And I just decided I was going to try to track what was going on and to track how Virginia was responding. So I think that's how I got into it.
Well, great. Well, based on the comments you see on your Facebook page, what do you think people are looking for in this data?
You know, some people look for arguments, you know, and debate. I think a lot of people want to try to understand what is actually happening in the state. What's the context in which all of this is occurring? So we have a lot of data, most of it pretty useful. There had been some glitches along the way that one can probably attribute to the fog of war in some sense. This was the first time we were fighting this war, and it's taken us a while to do certain things. But I think people are very interested in the context. So as Dr. LaRue just said, you know, Latinos make up a little bit less than 10% of the Virginia population, and they've been hovering around 50% of the infected cases for quite some time. I think it took us a long time to actually understand that realization and to think about what the public health and political response of that should be. And in fact, I'm still a little surprised at the political response from legislators and elected officials hasn't been more dramatic on that issue. Secondly, in terms of the context, I think the regional issue is extraordinarily important here, because it seems to me, and I could be wrong, that most of the numbers for so long have been driven by Northern Virginia and what was happening there. It looked to me in the context of this that Northern Virginia was almost sort of the southern tip of what I'd call the East Coast epicenter for this. And you take a look at that CNN map, and you just see it kind of goes from New York down to, you know, Maryland, you know, through Delaware, Pennsylvania, and then comes down to Northern Virginia, and then there's kind of a wall at Caroline County, and it didn't penetrate all that much as it did in Northern Virginia. And right now, I think a lot of the good data that we're seeing is because the data in Northern Virginia is so far down. But at the same time, other things are happening in the state. Slight tick up of numbers in Hampton Roads. I think a little more activity in the western part of Virginia. And so as we think about what we should be doing, I think we need to look at that sort of regional context. And then finally, I would say, you know, the other context I would look at is, I think at the beginning, we were so consumed by what had happened actually in New York, where the hospitals were overrun, that we were looking primarily for hospitalization data. and found out that the real situation that was really harming us was what we had seen in Washington State, which was the long-term care facilities. And again, here's a place that for just decades have probably been underfunded, and then have, even when they're privately owned, have extraordinary difficulty with either staffing in some instances or getting the appropriate PPE. And that was another place where I think the fog of war diverted us from a couple of weeks to understanding what was happening. But it's the context of the data that I think is most important here.
Okay. Are there mornings where you log in and download the data and start to crunch it and realize, I'm not sure what I'm seeing. I'm not sure what these trends say. How often does that happen?
I think it happens, it happens quite a bit. I think over time, we've seen some big trends that are, that are on the VDH data, or on, I would also say, the VHHA data on hospitalization, which I think are really important because they do talk a little bit about severity, particularly outside of the long-term care facilities where sometimes you don't see official hospitalizations. And I think we've seen those hospitalization numbers come down pretty significantly. We've seen the test positivity numbers come down. So we've seen these statewide trends looking pretty good. But at the same time, it's hard at times because the data lag, as Em said at the beginning. So all these numbers are going down right now, but this week we had a lot of people die in the last 5 or 6 days. I think today was like 36 people died. So that was a fairly significant number there. So, by and large, it's not always easy to determine on a day-to-day basis what these trends are. And then I think sometimes there's also on a day-to-day basis reporting glitches. Sunday numbers are a little different than Saturday numbers, or Monday numbers are a little different depending upon what goes on. So you have to be very, very careful, I think, in going back and saying, okay, these are the typical numbers that occur on a weekend before you actually interpret them to be extraordinarily meaningful.
So, it was mentioned earlier that the governor is making his decisions based on the data. Have there been instances where the governor made decisions whether to move forward or slow back when, to you, it wasn't really clear if the data supported it?
Overall, I think Governor Northam's been on the cautious side of those of the governors. I mean, that you've seen the governors who, want to, have really pushed the envelope a little bit in opening up. Governor Northam probably has taken more hits for being a little more cautious with the numbers. I think, if there was any time that he was a little more aggressive, it's right when they were opening up for phase 2. But that turned out to look pretty good, I think, for him. By and large, the public seems to be more supportive of him today than they were, when the pandemic started. So by and large, the kind of cautious approach he's taken, certainly antagonized a good number of people who, are upset with it. But by and large, when you look at the public opinion data, most Virginians are pretty cautious about this because a lot of people are risk averse. And I might add, I think the big issues that, coming forward in the next week or two, once we get out past the holiday of July 4th, people are going to start thinking about how are schools going to look? What are K-12 schools going to look like? What's going to happen at colleges and universities? And you're going to really see people express a lot of concern, and they're going to want to know information about how their children and the people who work there are going to be protected. I think that's the next big matter to come forward in Virginia, particularly because it's going to accompany this movement into phase 3.
Right. And I put this question to Luanne as well. Have you seen a difference or a deepening in the divide in the way the public looks at these numbers based on their political views?
I don't think I've seen an absolute deepening. Now, let me try to explain what I mean by that. I think the divide is serious. you know, on my Facebook page, I post a lot of articles. And anytime I post an article that suggests that there's some scientific basis for mask wearing, the number of people who object is you know, it's actually, you know, surprised me a little bit to this, because it just seemed to me that someone put in in one of the comments that I really liked, she said, you know, this is a small hinge that can open up a big door. You know, it's not that much of an aggravation to people, but it had become politicized. And so there's a group, but by and large, it's relatively small. And it's not just, you know, and I think it's a division among Republicans. I think by and large, most Democrats and independents are very comfortable with this, and so are many Republicans. It's just a relatively small group of folks who object to that. So, you know, there's a divide there, but I'm not sure it's deepened. It's just it's a divide between 1/4 of the population and about 3/4 of the population. And that 3/4 includes people from all political parties and all persuasions.
Okay. Well, great. Well, Bob, thank you very much. And I'm gonna, I think at this point in the program, we're gonna open it up to just the panel, the 4 panelists, to see is anybody like to go and just respond to something that another panelist has said that they'd like to clarify or perhaps take issue with.
I'd like to say something about what Bob said about the hospital data, and I think it's really great that the Virginia Hospital and Healthcare Association puts all that up. The problem I have with that, and the one piece of information that I think is really lacking, is even if they could break it down by region or by area, I had asked, is that available, and was told, call every single hospital. Well, I can't call every hospital every day and say how many people are in your ICU or on a vent. And I think that's really important, because, you know, we may have a lot of capacity here in Roanoke, but, you know, they may just be swamped on down there in Norton, you know, and so yeah, I think it's important to for people to be aware of that as well.
Yeah, and you know, one of the other things it doesn't address is how many people die in hospitals.
Absolutely.
I mean,
Absolutely.
that's not part of that database.
Right.
Right.
They
have a discharge number, but not a death number.
And they did clarify that the discharge number is live discharges. That's not people patients for another reason.
So there's anybody else on the panel would like to address an issue or that someone else brought up? We have.
I'd like to actually, I'd just like to hear Dr. LaRue talk a little more about the communication issues and how that could best be addressed in her mind with the folks in her communities.
Yes, thank you, Bob. That's a critical question. You know, I think, like I said in my statement, we need to make sure that all sectors of the community are getting the information and in a timely manner, not just getting the information, but making sure that it's timely about what phases we're in, what strategies are needing to be in place. I think it's critical for governments at all levels to be working with, in this case specifically, Latino leaders and community-based organizations that work with the communities that we serve, to really make sure the message gets out and it's getting out from a trusted source. You know, trust in government has been an issue in our communities for many, many years. Thinking just even ahead into right now, we're looking at, you know, vaccine development. Tuskegee not only happened here, but they replicated it in Guatemala, which is where I am from. And so I think there is some, you know, deep-rooted trust issues also that need to be addressed, and it's not just sufficient to just translate a message into another language, but really put it into the context for that subsection that we're looking for. You know, I think, you know, a varied modalities of communications. We've worked with certain jurisdictions to put together, like, for instance, a WhatsApp group. So we worked with one county that they've put together a business WhatsApp group that they spread information in Spanish, infographics, text around testing, food distributions, all sorts of COVID-related information. And it's been a great success. It goes out to the community. It's easily shared. It's a platform that is more commonly used than text messaging around the world, and especially in the Latino community. We use it to stay in contact with family members across the globe. So it's easy to just forward a text that way. I stopped counting the number of times I've done interviews, especially with the leading news outlets, so Telemundo, Univision. I did one even just last night in preparation for the holiday weekend. So I think we just need to be consistently getting out the messaging, also making sure, like I said, partnering with trusted sources and making sure that it's culturally the context also, and not just rote translations.
I think we'll finish up with one final question from the audience, and we'll put it to you as the VDH representative here. As Virginia enters phase 3, can you give us an idea of the numbers that the governor and the VDH staff will be monitoring very closely to determine if we're on the right track?
Yeah, so, and there's a individual dashboard that you can look at that has some of those numbers kind of already put together. So the governor's office will be looking at the key measures data that are available in that dashboard. So it's cases, as mentioned, both by the onset date as well as by the report date. Again, looking at those in conjunction can give more of a picture of the actual trend. Death information, again, both by date of death and by report date. The hospitalization data, that's about capacity that's been mentioned from VHHA. So that includes the number of beds that are currently occupied or available for any condition, the number of hospitalizations that are currently positive or pending a COVID test, and the number of hospitals that are reporting difficulty acquiring PPE, and then looking as well at testing capacity, looking for that kind of 10,000 tests per day average across the state, and then the percent positivity as well. So those are the main that are kind of in that key measures dashboard.
Right, and those are, just to clarify, those the key measures have been in place for quite a while now. Is there any change in those and any emphasis in any one of them as we enter phase 3?
At this point, I mean, we're constantly looking at all of the sources and trying to figure out which ones we think are the best bellwether, the best indicator of what we're actually seeing in the community. So I can't say that with certainty that this one will have more weight than another in the future. That'll all be kind of dependent on the quality of the data at that point. So we definitely may be introducing more sources, may definitely be weighting them in certain areas, but I don't have kind of set goals for that in mind right now.
Great. Well, thank you, and thank you to the entire panel for taking your time. I know everyone's working harder than ever right now during this pandemic, and thank you for taking the time out to be part of VPAP's panel. And for the audience, thank you for participating. You'll look for an email shortly for a quick survey if you'd like to tell us what you thought and what we can do better next time. So anyway, so I guess as this, we've entered that clumsy moment of how do you end a Zoom call? And so thank you very much. Have a great 4th of July weekend, everybody.
Thanks, you too.
Thank you.